Hello, may I share in this presentation a series of images that will demonstrate the power of 3D echocardiographic imaging in guiding two real-life procedures: a percutaneous closure of left atrial appendage using the Watchman procedure, as well as percutaneous closure of mitral paraprosthetic leak. For this presentation, these are my disclosures. And let's start with the real-life case presentation. An 81-year-old man with a progressive dyspnea and exertion over the preceding year. And this is what we know from his medical history. He has had persistent atrial fibrillation, and he has had recurrent GI bleeds while taking warfarin. However, the anemia, that it's chronic, requiring frequent transfusion, could not be explained by GI bleed alone, as there was a hemolytic component. In addition, he has a status post bioprosthetic mitral valve replacement, and it was a 29 millimeter Medtronic mosaic prosthesis of a porcine type that was implanted surgically about 8 years ago. And we also know that he has a series of comorbidities, including hypertension, diabetes mellitus, as well as a chronic obstructive pulmonary disease. So he was referred for a structural heart team with the two possibilities. One would be to redo surgical mitral valve replacement with concomitant left atrial appendage ligation in some surgical fashion, or to proceed with the possibility of two percutaneous procedures with the left atrial appendage closure using a Watchman device and percutaneous closure of a paravalvular mitral leak. Before we continue with the decision tree, we have to assess what's the risk for this patient regarding surgery, because that will determine whether we will take a surgical route or whether we take percutaneous route. And this is from his chart, and you see that there is a series of risk assessment, of which the most important one is the STS risk score of mortality, and his was a 4.8% or so. Just to give you a sense of scale, this is the STS score, or the Society of Thoracic Surgeons score that was developed several years ago, and this is the gamut of the risks from low risk to intermediate to high risk and prohibitive risk. And this is PROM, or predicted risk of mortality, and for our patient, you see it's about 4.8%, which is intermediate range surgical risk, which is not to be taken lightly to redo surgery given his age. And as you see, there is a significant risk of mortality for redo surgery. If you happen to be in Europe, you can use a Euro score, but the idea is the same, just to predict mortality and morbidity from a redo procedure in this patient. So let's divide his medical history in two parts. Let's first discuss the atrial fibrillation aspect. And let's image his left atrial appendage using transesophageal echocardiography. And this appears as a 2D image. However, it was drawn from a 3D echocardiographic image and represents simultaneous biplane view of the left atrial appendage. The left-sided image represents a left atrial appendage at the 0 degree, while the right-sided image represents a perpendicular or orthogonal view in the 90 degrees in this case. And it's extremely important to have this capability of biplane imaging for all the procedures, because simultaneously allows us to do two orthogonal planes in one image. And as you can see, the left atrial appendage is well visualized. There is neither smoke nor thrombus in this left atrial appendage. We can also turn the 3D aspect of it, And this is particular layout. On the left-hand side, there are 3 images. 2 represent long axis, and the bottom 1 represent short axis. Each of these 3 images can then be rendered as a 3D surface rendered image. And in this case, on the right-hand side, in the big screen, you see the rendering of the top left image, and that represent left atrial appendage in the long axis. We can also image the left atrial appendage in the short axis, and you can see the en-face opening of the left atrial appendage, its orifice, which is to the left of the mitral valve in this view. We also, between the left atrial appendage and the left upper pulmonary vein, we see what is commonly referred as Coumadin ridge, or the left atrial ridge that separates left atrial appendage from the left upper pulmonary vein. And at the top of the image is the pulmonary artery. Now that we visualize the left atrial appendage, demonstrates its orifice, as well show that there is neither smoke nor thrombus in the left atrial appendage, we can then proceed with the sizing this left atrial appendage in 4 canonical views: 0, 45, 90, and 135 degrees. In each of these canonical views, we measure the orifice diameter, it's a landing zone diameter, as well as the depth of the left atrial appendage in each of these views. And based on these numbers that we obtained for 4 canonical views, we can then determine what size of the Watchman device we will need to implant in this patient. And these devices come in 5 sizes that are 3 millimeter apart. This is the 5 sizes. They start from 21 millimeters and go all the way up to 33 millimeters. And just to give you a sense of size, the 24 millimeter Watchman device is roughly the diameter of a US quarter or 25 cents, also a quarter of a Canadian currency. So now let's conclude from this part of assessment related to atrial fibrillation. We can say that anatomy of the left atrial appendage is suitable for percutaneous closure using a 27 millimeter Watchman device. And then this is a image of a Watchman device. It's a nitinol frame covered with the cloth that it's at the beginning permeable to red blood cell and blood, but eventually will endothelialize and successfully close the left atrial appendage. And let's just review the steps of transcatheter closure of the left atrial appendage using the Watchman device. It starts with a transeptal puncture or transeptal cross, and it's a very important that is done in the posterior and inferior aspect of the fossa ovalis. And you will see why that is important. It's probably one of the most important aspects of this procedure. After the transeptal puncture is performed, then a delivery sheath is passed into the left atrium, and through the delivery sheath, a pigtail catheter is then advanced into the left atrial appendage. And after that, delivery sheath is also advanced into the left atrial appendage. Then an angiogram using iodinated contrast is done to see the appendagegram or the fluoroscopic imaging of the left atrial anatomy. After that, it's proceeded with the unsheathing of the device that is placed at the orifice of left atrial appendage, and then the device is deployed in order to close the left atrial appendage orifice. And after we are satisfied with the position of the device inside the left atrial appendage, we then prepare to release the device. An additional angiogram is done to check for leak, simultaneous to color Doppler assessment on echocardiography. And if we are satisfied with the position of the device is then released, and then initially it's permeable to blood flow through the device, and the flow through the device is normal. However, flow para-device is abnormal. Over time, the device will endothelialize and will become part of the normal structure of the heart. Let's start to implant in this particular patient, and we will start with the transeptal puncture, which is the essential part of this procedure. As I pointed out, it's extremely important to do transeptal puncture in appropriate portion of the interatrial septum, which will be in the inferior and the posterior aspect of the septum. But how do we communicate as echocardiographers the position of anterior, posterior, superior, inferior to an interventionalist? And I think the biplane transesophageal echo view is extremely helpful. On the left-hand side, you see the short axis at the level of the aortic valve, which allows us to recognize the anterior and the posterior aspect of the interatrial septum. On the right side of the screen, we see the orthogonal view, which is roughly the bicaval view, which then allows us to see the superior and the inferior aspect of the interatrial septum. And now the interventionalist has a map to guide their transeptal apparatus toward the desired part of the septum, which will be posterior and inferior. And once we are satisfied that the location of the transeptal needle, transeptal puncture is done. And I will demonstrate you on the next image of a 3D transesophageal echocardiography the importance of a posterior transeptal puncture. Here you see the en-face view of the left atrial appendage on 3D transesophageal echocardiography. In the position roughly about 10 o'clock, you see the left atrial appendage in its long axis. On the right side of the screen, you see the interatrial septum. On the top of the image is the anterior septum, and at the bottom part is the posterior septum. And you see if you do the transeptal puncture in the posterior aspect of the interatrial septum, then the path goes directly into the left atrial appendage. And this would not be the case had we done the transeptal puncture in the anterior septum. Thus, it's important to be in the posterior and inferior aspect of the interatrial septum in order for this procedure to succeed. Now that we have done successfully transeptal puncture in the appropriate portion of the interatrial septum, let's then go to Watchman deployment. And again, transesophageal echocardiography, particularly 3D echocardiography, is essential for the success of this procedure. Here we are looking at transesophageal echocardiography, 3D surface rendered image at the level of the left atrium. And you see on the right side of the image is the atrial septum, and taken at the moment that we are passing the delivery sheath over the wire through the interatrial septum toward the left upper pulmonary vein. Now that we passed the delivery sheath in the left atrium, we go to the next step, and you see here that the sheath is in the left upper pulmonary vein over the wire. And in the next step, we will move from the left upper pulmonary vein into the ultimate target, which is the left atrial appendage. And here you can actually see how 3D echocardiography can provide exceptional guidance to an interventionalist to go right into the left atrial appendage and minimizing a risk of damage to any of the surrounding structure. Now that the delivery sheath is placed in the body of left atrial appendage, we can start delivering the device. And here you can see again in a biplane view, side by side, two orthogonal views of the left atrial appendage as it's being closed with the Watchman device. So now the position is appropriate, the location of the device is appropriate, and now we'll check for its appearance of 3D. We can look at the en-face view of the left atrial appendage as it's closed with the Watchman device. In the middle of the image, we see the Watchman device, that it's appropriately placed at the orifice of the left atrial appendage, flush with the orifice without any shoulder. And then now I'll show you just in comparison what was at the baseline. On the right-hand side, you see the left atrial appendage. Before it was closure, you see its orifice. And now on the left-hand side, you see when it's closed with the Watchman device. In the final stage, we will then check for para-device leak using color Doppler echocardiography. And I'll show you a representative view here. And there is clearly no para-device leak on any side of the device. So we are completely satisfied, and it was a successful closure of left atrial appendage with the Watchman device. No para-device Watchman leak, that's what we want to see. And now on the right-hand side, you see images of the Watchman device, its nitinol frame, as well as a cloth on top of the device. And it's this cloth that provides the seal. So the guidance of the position of the seal inside the left atrial appendage is extremely important by transesophageal echocardiography, as it ascertains that there will be no para-device leak once the device is deployed. If you're interested in all details of this procedure, my colleague and I, we have recently published a paper in the Journal of American Society of Echocardiography on left atrial appendage occlusion or exclusion procedures that includes Watchman, all the details of the Watchman procedure that I have just demonstrated. Let's discuss the mitral bioprosthesis aspect in this patient. Originally, when he presented, the first procedure that was ordered was a transthoracic echocardiogram, and because he has been complaining of progressive dyspnea on exertion in the context of both GI bleed and hemolytic anemia. So these are important clinical clues when we interpret the following transthoracic echocardiographic images. So this shows you a parasternal long axis view in this patient, and in the middle of the image you see bioprosthetic mitral valve, which we already know that's a porcine Medtronic mosaic valve. The left ventricular systolic function is reasonably preserved, and we see that there is no rocking of the prosthesis. Now we will turn the color on to see if there is a significant mitral regurgitation. And actually you can see only a small degree of a color Doppler flow around the prosthesis, but doesn't seem very impressive. That would explain seemingly his dyspnea on exertion. We can also look in other views. For instance, we can look in apical four-chamber view with the color Doppler on. Again, the prosthesis is in the middle of the image, and it doesn't seem that there is a significant transvalvular or paravalvular mitral regurgitation. However, if you do pay attention in the back of the left atrium, there are color signals that might signify that mitral regurgitation is more significant than not. We can look at also a two-chamber view. Again, color is on, bioprosthetic valve, and again, there is no color signal that would tell us there is a significant paravalvular or transvalvular mitral regurgitation. However, we should not be fooled. We already know that the patient has a significant dyspnea on exertion and has hemolytic anemia. Therefore, there should be a very high index of suspicion that they might be paravalvular mitral regurgitation. But even on this transthoracic echocardiogram, maybe there is a little bit of color in the back of the atrium that might signify there is a more significant mitral regurgitation that we initially see. However, if we look at the continuous wave spectral Doppler tracing through the mitral valve in diastole, you will actually see that there is an increased velocity across that prosthesis. The peak velocity in this patient is 2.2 meters. And we know that at the time of implantation, the velocity was 1.8. So there is clearly an interval change in the increased velocity. And even had we not known the initial velocity of the prosthesis, we should always suspect paravalvular leak in situation where there is a velocity across the mitral prosthesis of the E wave is greater than 2 meters. And in this case, with elevated velocity of 2.2 might imply either mitral stenosis or mitral regurgitation. However, rapid deceleration of this E wave would strongly argue for mitral regurgitation and against mitral stenosis of this prosthetic valve. And we can support this diagnosis of significant mitral regurgitation with the tricuspid regurgitant jet tracing using continuous wave Doppler. And from this tracing, you can see that there is a presence of significant pulmonary hypertension, elevated systolic pressure, about 45 millimeters mercury, plus the right atrial pressure. So what can we conclude from this part of evaluation of the patient using transthoracic echocardiography? We can say that even if we do not see mitral regurgitation on color Doppler, we should always suspect it in appropriate clinical settings like hemolytic anemia when we see on continuous wave Doppler elevated E wave velocity above 2 meters per second. And because of that suspicion, even if we didn't see it on a color, transesophageal echocardiography was ordered. And then let's look at that transesophageal echocardiogram that was done in this patient. So let's image the mitral bioprosthesis. Again, 3D transesophageal echocardiography is extremely important in evaluation of prosthetic valve, particularly mitral valve. And see, there is a mitral valve in a so-called surgical projection or surgical view, where the aortic valve is on top of the image, roughly at noon, if you use the analog clock. Left atrial appendage is roughly at about 10 o'clock, and on the right side, about 3 o'clock, is the interatrial septum, and about 6 o'clock is the coronary sinus. And now we can see that there is a mitral bioprosthesis. We see a series of sutures that anchor the prosthesis to the native annulus. And then if we pay attention, roughly around 5 o'clock, there appears to be separation between a surgical ring and a native tissue. However, it's extremely important to recognize that this could also be a dropout rather than a true leak. So we have to use other measures and other imaging modality to confirm whether this is a true leak or a dropout. So we can turn on color Doppler, and I can see here that there is a significant paravalvular mitral regurgitation. The jet is present, but as you can see on 2D image is relatively small. And I'll show you now in the next image, which is a 3D image, how much bigger this jet is. And actually see here roughly about 5 o'clock, you see that this is a paravalvular mitral regurgitation with a very large jet. And you see there is a difference between a 2D and a 3D. And this is essentially what we might say a spoon jet. In a 2D or any cross-sectional images, if you think about the spoon, we just see only this portion of the jet. However, on a 3D, if you rotate, we then see the anfas and see the full extent of the jet. And that's exactly what this 3D image shows, that there is a very significant paravalvular regurgitation. And then we can do this paravalvular regurgitant jet evaluation using multiplane reconstruction. And a multiplane reconstruction imaging is done in a 3D echocardiography as well as CT and the MRI imaging. The top two images represent long axes, and the bottom left represent the short axis. And the bottom right is just a 3D rendering of the mitral prosthesis in this case. And based on this multiplane imaging, we can locate the jet in its short axis in the bottom part of this image. We can not only locate, but we can also size this jet. And you can also notice that there are two paravalvular leak. One is the dominant on the left and a much smaller on the right side of the bottom image. And then how do we size? We can actually, again, use multiplane reconstruction with this 3-pane image. We can blow up one of them images with the short axis, and then we'll precisely measure this paravalvular leak, which will be essential for choosing the size of a plug to close this leak percutaneously. So that's the big leak on the left and a small leak of the right. Now that we size the device, we can also use something called the reference plane or RP thickness to really give nice impression of the shape and the location of this paravalvular leak, both larger one on the left and a smaller on the right. And if I may just digress for a moment about what the reference plane thickness is. On the one hand, there is a 2D imaging is on one end of the spectrum, and then 3D imaging is on the other end of the spectrum. In between, you can have some intermediate imaging. That is to say that it's a partial 2D, partial 3D imaging, and that's what a reference plane thickness is. So essentially, you can have this image that it's roughly 20 or 30% 3D on top of the 2D image, and this is particularly useful for visualization of paravalvular leaks. We have also found it useful to imaging, for instance, vegetation on a native or prosthetic valves as well. Now let's conclude with this portion evaluation. We can conclude that the patient has severe paravalvular mitral regurgitation presenting with dyspnea and hemolysis, and he was referred then for percutaneous paravalvular leak closure. So now let me guide you through this portion of the procedure, mitral bioprosthesis PVL closure. First, let's look what kind of prosthesis he has. As mentioned earlier, he has a 29 millimeter Medtronic mosaic porcine bioprosthesis. And this is the image of such a prosthesis. And you see that there is a black dot at the top of the strut, and that's the only radio-opaque part of this prosthesis, which represents a significant challenge in fluoroscopic imaging of the prosthesis and therefore in fluoroscopic guidance of paravalvular leak. And therefore, transesophageal echocardiography will be exceptionally important in guiding paravalvular leak closure in patients like this. And let me just show you a chest x-ray of this patient and what I mean that the lack of radiopacity of this prosthesis. So this is a chest x-ray of this patient, and I will blow two parts of this image. So this is his mitral bioprosthesis, and actually see there are only 3 radiopaque markers on this bioprosthesis, which are at the tips of the struts and away from the sewing ring. And it is at the sewing ring that the paravalvular leak occurs, and it's at the sewing ring level that the paravalvular leak closure will be performed. So therefore, these markers do not provide us with the fluoroscopic location of the sewing ring. And the other part of the chest x-ray, just to remind us that this patient had already undergone successful Watchman device closure of the left atrial appendage. So now I'll give you a series of radiographic images of a different bioprosthesis and actually see that this particular prosthesis that the patient had, Medtronic mosaic, is the least radio-opaque of the series of bioprosthetic valves that are commonly implanted around the world. So now let's start with the mitral bioprosthesis PVL closure using 3D imaging. Again, we'll recognize that this is a bioprosthetic valve in the mitral position, visualized in a so-called surgical view. And you see that the transseptal procedure has already been done, and that there is a catheter across the interatrial septum, and then through the catheter is the wire, and the interventionalist is trying to pass its wire blindly through the paravalvular leak. Maybe we can help interventionalists and increase the success and ease of passing this wire through the paravalvular leak. How can we do that? So we can actually combine the 3D echocardiographic imaging with fluoroscopic imaging in what's referred to as fusion imaging. So now you can see again 3D transesophageal echocardiographic imaging of a bioprosthetic valve with a significant paravalvular leak at 5 o'clock. And in the bottom part of the image, you will see the TEE fluoroscopic image. Now that demonstrates that we are in a dual mode imaging of fusion imaging between 3D transesophageal echocardiography and fluoroscopic imaging. Using specialized software, we can then place a marker at the location of paravalvular leak on a 3D transesophageal echocardiographic portion. And here you can actually see that we have placed a marker directly at the paravalvular leak. And now this marker that it's placed on a 3D transesophageal echocardiographic imaging will be projected into the fluoroscopic space for guidance by the interventionalist. Now you can actually see mitral prosthesis together with the wire passed through the paravalvular leak exactly at the location where the marker was placed on a 3D transesophageal echocardiographic image. But now let's move to the fluoroscopic space, and essentially you see that this dot that we labeled as a 2 is actually projected in the fluoroscopic space, and it's exactly through that dot that the interventionalists passed the wire to go through the paravalvular leak. So therefore, this demonstrates the power of a combined fusion imaging, transesophageal echocardiographic imaging, where we placed and localized the PVL, and then that image is projected into the fluoroscopic space, allowing the interventionalist to successfully pass the wire through the paravalvular leak. In the next step, you see that the device, a closure device or a plug, is placed into the paravalvular leak to close it. And now I will show you a series of these devices. These are AVP devices or vascular plugs. They come in 4 varieties. In this case, we use the AVP2 Amplatzer plug, which has 2 short discs and a larger disc in between. So just to see what the appearance of these devices when you compare them on fluoroscopic and 3D TEE imaging. And now we will proceed with the deployment of this AVP2 plug inside the paravalvular leak. Now again, this is a 3D transesophageal echocardiographic image in the surgical view, and you see that now a plug is being opened. The left atrial disc is opened, closing the paravalvular leak. In the next image, we can release the device, and we will check also with the color Doppler and other imaging modality whether there's satisfactory position or not. Now you can see the nicely placed device. It's stable and closing the paravalvular leak roughly at 5 o'clock on this surgical view of the mitral prosthesis. And that's the highlight, the location of the AVP2 at the side of the mitral bioprosthesis. And now we can turn on color to check if we have closed this leak. And it appears that there is a residual flow between the left ventricle and the left atrium. Now we can ask ourselves, was this a successful closure or not? So it's important to recognize that after placing the device, there will be continued flow through the device, and will only after several weeks, when the device endothelialize, that will be complete closure. So this is essentially satisfactory and a successful closure of paravalvular leak, and the flow will stop in several weeks. And actually you can see this from a review article of these devices. Essentially the authors concluding, strictly speaking, that these devices are not plugs that can instantly close or seal the leak, and essentially takes some time, several weeks, to endothelialize and close this procedure. And now may I conclude this presentation with 2 major points. One, that 3D transesophageal echocardiography is essential in guiding a variety of percutaneous procedures. In this presentation, I showed you the utility of 3D TE guidance of a Watchman procedure for closure of the left atrial appendage, as well as a 3D TE guidance of paravalvular leak closure. And in case of paravalvular leak closure, we have augmented the power of 3D echocardiographic imaging with the fusion imaging between echocardiography and fluoroscopic imaging. I would like to thank you, and I hope you enjoyed this presentation. I would also like to thank my team and the numerous people who were involved in these procedures. I would like to thank Dr. Larry Chinitz, the leader of our electrophysiology program, where the Watchman device was implanted, as well as Dr. Matthew Williams, the leader of our structural heart disease program. I hope you enjoyed this educational presentation, and thank you very much.